Good morning, everyone, and welcome to our Thyroid MBS session on for Friday morning. Welcome to everybody who's joining us live, as well as those who are going to be watching this the video version of this. It's my pleasure to introduce our panel this morning. Our primary presenter is Dr. Jenny Hoang, who's an associate professor of radiology at Johns Hopkins Medicine. She wears a number of other hats. She is vice chair of radiology enterprise integration, as well as medical director of Johns Hopkins Imaging. In addition to completing 2 fellowships in neuroradiology and cardiothoracic, that's an terribly interesting combination. To have both of those radiology fellowships under her belt. She also received a master's in health science, as well as an executive MBA from Duke University. And so I dare say she is well-schooled and highly informed regarding the topic of this morning's presentation. We are also joined today by someone who has presented on the Thyroid program in the past, Dr. Naykky Ospina, who's an endocrinologist and healthcare researcher at the University of Florida. We welcome her back. And for those of you who don't recall, Dr. Ospina's research on shared decision-making is very, very important work, and it is sponsored or supported by a Career Development Award from the National Cancer Institute. And so with that, we have a really extremely interesting and very timely topic for this morning's program. I encourage everyone to send in their questions, and I will do my very best to get to those questions before the end of the hour. And so with that, Dr. Hoang and Dr. Ospina, thank you very much for joining us, and I will turn over the program to you.
Well, thank you for that kind introduction, Mark, and hello to everyone out there joining live and to people that are catching up to this recorded session. Let me share my screen. Okay. You see my slides now? Okay.
All set.
Okay, wonderful. So I am presenting a paper that was published in Thyroid this year. The title of the paper is
an Australian and
okay. The title of this paper is an international survey of utilization of 5 thyroid nodule risk stratification systems, a needs assessment with future implications. And before I even tell you about the aims and methods of this paper, I'm personally always interested in why researchers write the papers they do and spend hours and hours collecting the data and working with all the collaborators. So let me tell you first a story of why, and the why is on 3 levels. Okay. So first level of why is I was on the committee that developed ACR TI-RADS, which is a risk stratification system, abbreviated as RSS. And the purpose of ACR TI-RADS, as well as other risk stratification systems, is to address problems like this one on the next slide. This is a radiology report from a friend of mine whose sister is an attorney, and this was her report. And this friend of mine is a radiologist, and he texted me the report and said, "I don't really understand it. What do you think my sister should do?" And so let us all look at this report, which tells us why ACR TI-RADS was developed. This radiologist reported that my friend's sister had 2 thyroid nodules. One is in the midpole of the right lower lobe that measures up to 10 millimeters. And there's one feature of the thyroid nodule that it is hypoechoic. And then another nodule within the lower lobe, not telling us which side, there's another nodule, 4 millimeters. And again, one feature of that nodule, which is hypoechoic. Now, for everyone that reports and acts on thyroid nodules, you know that this is not sufficient. You can't make management decisions on this, but yet this radiologist has, and the radiologist has recommended that this nodule, with some typos, there's an Arthur lobe apparently in the thyroid. I had no idea about that. And has recommended that we can consider a follow-up, or we can consider an FNA of that nodule. And so I hate to say it as a radiologist, but this is a bad report, a really bad report. And what I realized is that another radiologist, maybe in the same practice, or maybe the same radiologist the next day, may report this ultrasound differently. So there's variability in reporting and variability in management recommendations. This radiologist is basically given the provider the decision of what to do, and this provider may not be an expert. And all of this leads in variability in patient outcomes. And this leads to excess ultrasound biopsies and overdiagnosis of thyroid cancers. And this is just not good patient care. So that's the first level of why, and why I was so invested in developing ACR TI-RADS. This is the next level of why. This was the response from radiologists when ACR TI-RADS first came out. And I read these out to you. These RADS schema, because there's also BI-RADS and lung RADS, there's lots of RADS. These RADS schema are metastasizing. That's a very medical term. It's difficult to keep track of them all. Okay, and I think that's a good thing that we are introducing radiologists with more standardized ways of reporting and recommending management. So I like the fact that the RADS schema are metastasizing, and TI-RADS was just one of them. Someone else said, yet another useless classification system that academics have put together to supposedly program us. Ouch, that hurt, because I spent more than 2 years of my life on ACR TI-RADS, and I was not intending to program anybody. Okay, and then the final one, which led us to think more about a universal risk stratification system. This person's saying, I think you can pick a system and consistently apply it. You're ahead of the game. Does it really matter which system you pick? And they're referring to the fact that before ACR TI-RADS, there was the SRU criteria for radiologists, and in North America, commonly used is ATA. And then I was at a meeting just in New York earlier this year. One of my live in-person meetings. It was an absolute pleasure to present to a live audience. And someone that was there virtually had this comment after I spoke about ACR TI-RADS. This radiologist said, I found TI-RADS very helpful, but many endocrinologists appear not to recognize the value of TI-RADS and use ATA guidelines instead. To me, it's a problem in cross-communication with clinicians, absolutely. If your radiologist is reporting with TI-RADS and you're using ATA as an endocrinologist, how confusing is that to everybody? Any thoughts on how to improve the approach so endocrinologists and other clinicians and can either come on board or propose a different algorithm, okay, where we're all in agreement? Okay, so that's the next level of why, and that's why our fearless leader, Franklin Tesla, who's also the senior author on the paper, put together the stars of thyroid ultrasound, and he formed this committee, the International Thyroid Nodule Ultrasound Working Group, abbreviated as ATNUWG. And it was a global membership. Here are all the members. These were the original members, and we've since had more members. We've got representatives from Europe, from Asia, Korea in particular, as well as the United States, representatives from the ATA. And it was the goal of this committee to come up with a universal lexicon as well as management recommendations for thyroid nodule ultrasound. Okay. And so that's the first two levels of why. And then the direct origin of this paper actually came out around the time that COVID started. And I know that this whole Thank Foundation Journal Club and all these seminars we're having came out of COVID. This was a paper that actually came out of COVID. And it was an email that Laszlo, one of the co-authors on the paper, emailed me because I emailed him asking him about how they were doing in Europe with COVID, and also asking, what is your practice there with risk stratification systems? What do your members think? And then he wrote a very long, thoughtful email, which concluded with that we're developing a universal risk stratification system, but we really should have a better understanding of what people want. We know what these committee members want, but let's see if we can poll our users. And so back in April of 2020, these giants got together, Franklin, Laszlo, Cosimo, Enrico, and they created a survey to poll users of risk stratification systems, people that care about thyroid nodules, about their opinion about what the new universal risk stratification system should look like. So I've told you now the three levels of why, and now let's get into the paper. So the paper, the aims of the paper, the overarching aims was to inform the development of a universal international thyroid risk stratification system. So people from Asia, Europe, the United States could look at a thyroid nodule, use the same terms to describe the thyroid nodule, and have the same way of categorizing the risk and have the same management recommendations. And that's across all specialties. Can you imagine this future world? How amazing that would be? So that was the goal of this committee. And the specific aim of this paper was to look at the factors that are associated with our choice of risk stratification systems currently and barriers to the risk stratification system. So I'm going to pause here and let the audience, you can either put it in the chat or write it down on a piece of paper or just lock it in your head. What do you think determines whether someone uses ATA, ACR TI-RADS, EU TI-RADS, Korean TI-RADS? Okay, think about it, lock it in your head. Okay. All right, let's keep going. And so this was a question we wanted to find out, but we also wanted to quantify. And I am going to admit, I'm sort of biased because I'm been so committed to ACR TI-RADS as a radiologist. I personally think ACR TI-RADS is the cream on top of a huge gâteau. I think it's the best of the best. And I was hoping that we would see that users were using ACR TI-RADS, but I did realize that perhaps there would be more radiologists using that risk stratification system. So the methods, it's a survey paper. The leaders emailed, had permission to email 5 societies with the survey, and they were the ATA, the AME, the ETA, the Korean Society, and the SRU members. And the survey was a long survey. It would have taken about 10-15 minutes to do the survey. So not everyone answered all the questions, and it was really difficult to get an idea of what the response rate was. But we asked questions, and then we did a subgroup analysis to identify the factors that led people to use one or more of the risk stratification systems and determine their preferences. So what we were particularly interested in the cohort were how much ultrasound they did, their training, their specialty, the practice type, and then where they were from in the world. Okay. And let me tell you the risk stratifications that we were interested in. There were these 5 main ones: the AACE, ACR TI-RADS, ATA, EU TI-RADS, and then Korean TI-RADS. And at that time, it was the version from 2016. And you look at them and you realize that they're all similar in ways, but they're different. In particular, let me draw your attention to the method of risk stratification. ACR TI-RADS is based on points, and the points sum up to a risk category. ATA is wildly different and is somewhat confusing for radiologists to use because it's based on pattern matching. And I'd say that in private practice, the people that report thyroid ultrasounds aren't doing them all the time and not probably as skilled as endocrinologists in putting together the patterns. So this was problematic for radiologists and challenging for them to use. The response we've received is that it's much easier for them to use ATA TI-RADS. And then the other classification systems use a more algorithmic approach where it's combination of features. So a little easier for radiologists to use, but still the points-based system, our members in radiology have responded very positively to. And then the number of risk stratification categories are also very different. Okay, so these were the big five that we were interested in. Okay, so in terms of results, who responded to this survey? Well, it was overwhelming. It was 875 people responded to the survey from 52 countries. That is a lot of the members of these societies, and we really appreciate that. And so let's see who they are and how they're similar to you or someone else in the United States. So the age, they were pretty well distributed across the age groups, pretty well distributed across male and female. So nothing to point out here. And then where they were from. So let's take a look. Europe, the majority were actually from Europe, so 54%. So shout out to Europeans who may be better at responding to surveys than Americans, or maybe at that stage, COVID was running through United States more, I don't know. So a lot of Europeans responded, so that definitely biases the result in some way. And so that subgroup analysis is important. More attendings responded than fellows and residents. And then in particular in endocrinology, more than half of the respondents were endocrinologists. So again, that subgroup analysis is really important then. After that, it was radiology, then surgery. Okay, and then this chart, nothing much to point out except that the majority were in academics. We asked questions about how much thyroid ultrasound they did and also their experience in performing biopsies and their volumes, because we wanted to see if that would influence people's choice of the risk stratification. It turned out it really didn't. Okay, so then what did people think about risk stratification systems? And the key thing I want to point out here is that was a question about, do you think that risk stratification systems are of value? And we were pleased to see that a key point here that more than 90% strongly agreed that the risk stratification systems do add value. So looking at that second slide I showed you, or third slide of that radiology report, if that radiologist had used a risk stratification system and a template, then that patient would have gotten a much better assessment of the thyroid nodule with all of the features reported, not just the echogenicity. Okay, so people agreed that it was of value. And interestingly, excuse me, people thought that the points-based system was actually most favored. So that's the ACR TI-RADS method of assessing the nodules for risk. Okay, then did they use risk stratification systems? And remember, I'm the person backing ACR TI-RADS, so I'm inherently interested, which did they use when the survey came out? So 692 people use risk stratification systems, so that's about 2/3 of the 875 that responded. And here are the 5 risk stratification systems, and this is the use of the risk stratification system. So ATA is 34% used ATA. So this is not just if you used ATA alone, but if your organization, your institution used ATA. So ATA was used in the practice 34% of time. ACR TI-RADS 33.4%, 33.7%. So very close. EU TI-RADS is third, AAC, and then Korean TI-RADS last. And these numbers, of course, don't add up to 100% because this is if you use it at all. So there's people that use more than one risk stratification system in their organization. Okay, so that was actually very promising to me because given the majority were in Europe and the majority were endocrinologists. So for ACR TI-RADS to be used that frequently, that was very encouraging. Okay, so the next key point that I wanted to share with you is this one. That to my horror, I realized from the survey that nearly a third of people use more than one risk stratification system in their institution. And so what does this mean? I'll share that with you later. And it wasn't just 2. This very confusing table is intended to look chaotic because this is how I felt when I saw the results. Okay, so there were a number of people that used one risk stratification system, but there were people that used up to 4 risk stratification systems in their organization. How crazy is that? Okay, so it was like only one person, but a lot of people use 3 risk stratification systems. And if you use 2, the most common ones, and I would say this is the most common scenario in North America, where the radiologist is using ACR TI-RADS and the endocrinologist and the surgeons may be using ATA. And then here is the second most common scenario, ATA with EU TI-RADS, and then the AAC with the ATA. Okay. When I saw these results, that honestly was the reason that I was so motivated to get these results out to the thyroid community, to let them know that because we have so many risk stratification systems, this is really confusing for providers, to patients, and leading to inherent inefficiencies. And therefore, it further supports the argument of having a universal risk stratification system. Okay. Now, back to the question I asked you earlier, what do you think determines the use of the risk stratification systems? So in table 5, I have the only 2 factors that were statistically significant in determining the use of risk stratification systems. And here are our 5 risk stratification systems that we studied across in the columns. It was specialty and geographic region. So if you had those locked in as your answer at the very beginning, 100% to you, exactly. So that told me it didn't really matter what the research was showing comparing these risk stratification systems, even if the research showed that one of these was stronger. We are loyal to our specialties and we are loyal to the regions that we practice in. So let me share with you some, let me highlight this. So with the AACE, the majority of users were endocrinologists and the majority of users were from Europe. With the ACR TI-RADS developed by radiologists, the majority of users were radiologists, and it was developed in North America, so the majority of users are from North America. ATA, the majority of users are also from North America, and the majority of them are in surgery, and second to that is in endocrinology. EU TI-RADS, endocrinology, most commonly using that, and then from Europe. Okay, so it's most commonly used in Europe. And Korean TI-RADS, oh yes, of course, the majority of users are in Asia. So again, highlights the point that we're loyal to our specialty and we're loyal to our geographic region. And this accounts for the multiple risk stratifications systems that are used. And that was our third key point. So let's get to the discussion. 91% of respondents were in favor of risk stratification systems. They saw value in it. So we're on the right track. And then the choice is dependent on the medical specialty and the geographic region. And what's the problem with this variability that we're seeing? It's leading into my next slide, leading to, if we're using multiple risk stratification systems, it's leading to patient confusion with different management recommendations. If a radiologist is dictating a report and recommends follow-up, and then the endocrinologist applies ATA and then recommends biopsy, how confusing is that? And I know Naykky's written about this practice and what we should be thinking about in our reports as radiologists. And then think about the inefficiency that as an endocrinologist, you're taking our radiology reports and then you're recategorizing and applying ATA. Why didn't we just do it for you from the beginning? And then there are errors related to reclassification. Just seems like an incredible waste of time when we're all already so busy. Okay, so limitations of this study. Most respondents were from academic practice and most were endocrinologists. So we're not really capturing everyone that uses risk stratification systems. And furthermore, there's obviously a response bias. If I'm sending a survey to you entitled Risk Stratification Systems Usages and Needs, do you think that someone that hates risk stratification systems is really going to spend 10, 15 minutes doing the survey? Probably not, right? And then finally, we're unable to determine the response rate because we're unable to see who actually opened the email and who we reached. So I conclude here, and I've got a couple of minutes left. There is value in risk stratification systems, but there is inherent problems with having multiple risk stratification systems being used. And in this paper, we were able to quantify the variability. We showed that nearly 1/3 of the respondents use more than one risk stratification system in their multidisciplinary practice. And so this further supports this need to develop a unified, universal system for practitioners and patients. And I am going to conclude here, and I thank you for this opportunity, and I look forward to hearing the discussion and also hearing from Naykky. Thank you very much.
Well, can everybody see my screen? Just making sure that.
Yes, we can.
Yeah, so thank you again for the invitation and the opportunity to talk about the implementation of thyroid nodule risk stratification, and really the opportunity to put some of the excellent points that Dr. Hoang highlighted in her paper. So I will focus really on 2 points. First, just kind of like discuss why we should be considering thyroid nodule risk stratification. And then I want to provide kind of like a vision of what things can look like in the future using the implementation science lens to discuss how we can improve the care of patients with thyroid nodules. So why should we consider thyroid nodule risk stratification? So on the bigger problem that we're trying to solve is that, there's a high prevalence of thyroid nodules in our population, and there has been increased detection of these nodules. That's in part to increase access to care for certain populations, but also to the widespread availability of imaging technology. So for the clinician, what you are kind of like having to balance is on one side, the risk of overdiagnosis if you're too liberal with kind of like the evaluation of the thyroid nodules, that then once the diagnosis is made of a thyroid cancer that is low risk, you're kind of like increasing the financial burden on the patient, as well as side effects from treatment. They will have decreased quality of life, and so on. And then on the other side, you're trying to balance not missing or delaying the diagnosis of a clinically relevant thyroid cancer. And as you might be familiar, despite the fact that, as you can see here in this light green, there has been a significant increase on the number of thyroid cancer diagnoses during the last few decades, the mortality, remains to be low and relatively flat. So this kind of like balance here of risk of overdiagnosis, those harms affect a lot of patients. So one potential stop in this kind of like diagnostic cascade is that decision to perform a biopsy or not, and then to move forward with treatment and other things later on. And risk stratification can definitely help us with that decision on whether a biopsy should be performed or not. Now, kind of in terms of how thyroid nodule risk stratification can help us, I have listed here the positive things of thyroid nodule risk stratification. So one, it can allow us to estimate the risk of thyroid cancer in a particular nodule. So that's very helpful. Clinically, you will be concerned for those that have higher risk compared to low risk. It could decrease the number of unnecessary biopsies, which again is one of the main problems that we're trying to solve. It can improve communication between clinicians because patients with thyroid nodules are seen by primary cares, gynecologists, surgeons, emergency room physicians, and so on. So this allows people to have a structure, as Dr. Hoang mentioned, and then that can lead to consistency in evaluation and care. So I also would say that I will have a bias that I think that thyroid nodule risk stratification is something that needs to be done. But there are some caveats to all these positive points that I have listed here on the left. For example, in terms of the estimation of the thyroid cancer risk, so we know that the body of evidence that kind of like let us know what is the risk is moderate to high risk of bias, in a way because of this design in which the samples are going to be enriched with the patients that are undergoing surgery or repeat biopsies and so on. Most of the estimation of thyroid cancer risk is based on papillary thyroid cancer, which is the most common. And once NIFP has been now considered like not cancer, some of the literature is mixed because again, if NIFP was considered cancer, then the estimation of the cancer risk will be higher. So those are kind of like all important caveats there on how accurate that estimation of risk is. In terms of the unnecessary biopsy, mostly you will have this defined as a benign biopsy. And as a clinician, there are scenarios in which the result of the biopsy might be benign, but by no means was that biopsy unnecessary in the particular situation of the patient. And then for the last two, in terms of improved communication and consistency, one of the things, as Dr. Hoang discussed, is that we rely on kind of like our groups and with and societies. So there might be an over-reliance on the recommendations for biopsy or not. And there can be then confusion when the recommendations are not the same. So for primary cares and gynecologists and other surgeons that might not be familiar with all the technicalities, this kind of like over-reliance on the guidelines or the authority can actually be problematic in practice. And similarly, there can be patient concern when, depending on what stratification is used, there's really not that consistency in evaluation and care that is the final goal. But having said all of that, if you just were to look at these two thyroid nodules and say that based on their appearance and on a systematic approach to evaluate the risk of cancer in each of these nodules, I think there's no doubt that there's a positive effect on patient care and outcomes of stratifying nodules and not treating all the nodules as if they were the same, because the ultrasound provides significant insight. And if that insight can be communicated in an organized fashion between clinicians and patients, as I said, the effect is going to be positive. So in terms of the kind of like implementation science approach of thinking, sharing a little bit of a vision of how things might look in the future, you all might have heard that it takes 17 years for research evidence to actually reach clinical practice. And as Dr. Hoang presented, if we look at the thyroid nodule risk stratification, they have all been endorsed in the last 5 years. But the research that led to their endorsement kind of like dates even a few more years. So we're kind of like probably on track for this 17 years of time between research evidence and clinical practice. So there would be a lot of interest in trying to expedite the adoption of thyroid nodule risk stratification. Now, if we think of thyroid nodule risk stratification as an evidence-based practice that improves the care of patients with thyroid nodules, then our focus should really be on one, increasing the adoption. So that would be that most patients that have a thyroid nodule and have an ultrasound, they will have that nodule categorized according to risk. And then second, that this risk stratification is done to high quality, because also the clinical evidence that we have is mostly derived from academic centers, high volume with highly expert radiologists or clinicians. So we need to make sure that in routine practice, they continue to do this risk stratification to the highest standards of care. So these are, as I see, the two main problems that we should try to address moving forward. Now, when you think about implementation science, think on one way that you have your evidence-based practice that you know will lead to improved outcomes for patients. So in this scenario, our evidence-based practice is the thyroid nodule risk stratification. And then the outcomes that we can improve, I have just listed a few, but you can imagine or add some others here. So we already talked about kind of like unnecessary biopsy, and I have put here the little asterisk on how do we define an unnecessary biopsy. The clinician communication in terms of the referring physicians, the radiologists, and the clinicians that will do the biopsies, and then making sure that the care that the patients have received is patient-centered. Now, if you have this evidence-based practice that you want to implement to increase outcomes, you need to make sure that it's adopted. And as I said, that means that most patients with a thyroid nodule will have thyroid nodule risk stratification as part of their care. And to really lead to that adoption, then you need to understand what are the barriers and the facilitators for people to actually use risk stratification in your practice. Because at the end of the day, even if the evidence-based practice has proven beneficial and we have all the data showing that it's good, if people do not adopt it and don't do it in practice, then there's not going to be an improvement in the clinical outcomes. Now, when you're thinking of the reasons why people are doing or not risk stratification, thyroid nodule risk stratification in practice, we can follow one of the frameworks of implementation science, where first you kind of like think of the outer setting where that person is practicing. And as it was discussed on the paper, this can be like the country where you practice or the healthcare system where you practice. So there might be some differences with whether it's a kind of like universal healthcare system versus the one we have in the US. So all of that can affect kind of like the implementation of that strategy. Then you will have kind of like the inner setting, and you will be thinking here about clinics or departments. So doing thyroid nodule risk stratification might look different for the regular day-to-day life of the endocrinologist versus the radiologist versus an endocrine surgeon. Now, you think later on about the individuals. So similarly, it might be different what the endocrinologist or the radiologist will think, as well as the patients who are reading and receiving these reports nowadays. Then you think about the strategy itself or the evidence-based practice. So in this case, is the intervention is the thyroid nodule risk stratification. And the paper we just heard about really was focusing on things as, should we do pattern-based or points? How many categories? Which system? Should we have just one universal intervention? Or the fact that there are many interventions or many ways to risk stratify, is this decreasing adoption? So really the paper focused on one of these components of all the things that you should consider on why people are not adopting the evidence-based practice, in this case, the thyroid nodule risk stratification. And then lastly, you think about the actual process. So you have basically an endocrinologist practicing within an academic center within the US, with patients that have access to care, to their notes, using both ATA and ACR TI-RADS within their institution, and then the actual process of doing that risk stratification. Are they using a template? How much time is this taking for them? And all of this will affect, the adoption and the quality of the risk stratification in practice. Now, so going back to our kind of like little schema here, the first thing you want to do then to make sure that this is adopted is to understand the barriers and the facilitators, so that then you can create implementation strategies, which are just things that you're going to do to remove the barriers or ameliorate them, because many times there are some barriers that you cannot remove, or potentiate things that are facilitators. And at the end of the day, once you have this kind of like organized and logic way of approaching the problem, then you will increase adoption and then have the positive effects on the outcomes. So thinking of some kind of like general implementation strategies. So obviously access to new funding, right? So if you're starting a program, you're in a clinic where thyroid nodule risk stratification is not being done, so then you might request that you want to start the clinic now with thyroid nodule risk stratification. Another important one is eminence, which sometimes you can understand as the guidelines. And this is some of the work that the current paper is addressing, which is many clinicians will feel comfortable following guidelines because there's a level of trust within your organization. So this eminence is kind of like working from that order setting to making people adopt that practice. Then you might need to develop, distribute, and maintain education programs, because people need to feel comfortable. They need to have self-efficacy, so that they are doing a good job on the risk stratification. Then the other big one, in addition to guidelines and universal lexicon and approval, is, for example, economics. So for example, many times if you have a new way of doing things or an innovation, you can put this on a fee-for-service list. So for example, suggesting that reports that don't use thyroid nodule risk stratification are lower quality. So then the ones that use thyroid nodule risk stratification should be reimbursed higher. These are things that obviously have a lot of impact because they come from that other setting of where people are practicing. A local need assessment and consensus, that is, as we have discussed, because things are very different in a private versus an academic center in the US, in Europe, in an endocrine clinic, versus a surgical clinic, and so on. So you need to have kind of like that endorsement or eminence, but at the lower level as well. So that could be, that the that the chair or that the group from radiology or endocrinology are supporting that, we do risk stratification and we do it this way. And then lastly, once clinicians are doing the thyroid nodule risk stratification, you can then focus on their performance or giving them feedback on whether they are doing this to a high risk, to a high quality, which was the other point that I want to mention. And I wanted to just kind of like show you this example or this additional way of thinking of the problem. So on one side here on the y-axis, you will have the clinical benefits of thyroid nodule risk stratification. And just to use a ACR TI-RADS as an example, compared to other systems and to the usual care, this might have a rate of 25% of unnecessary biopsy, which is the lowest among all the other systems. And as I mentioned, though, this is really from data that comes from the ideal context. So these are ultrasounds that were read by the expert radiologists or clinicians in high volume academic centers. But now, when people start doing this, so they do adoption, you want to make sure that this is being done the way it's supposed to be done. And there are going to be barriers to that. So the knowledge based on previous training, or based on the volume that you have. Like the more ultrasounds you read, the higher your self-efficacy as well. So knowledge could be a limitation to achieving that kind of like effectiveness that we see on the studies. The skills of the person, and then the time that they might need, right? Because it might take longer to put that full report and to do that assessment nodule by nodule compared to writing something shorter, as the report Dr. Hoang showed. So then once you are doing the evidence-based practice, but not to the higher standard, then you're going to have this decrease on the potential clinical benefits. And this is just from one systematic review that looked at the reproducibility of TI-RADS, ACR TI-RADS in practice, and found that it was about 0.5, which again, levels more than 0.8 will be probably ideal for an intervention in clinical practice. And then once you kind of like end up in a non-ideal regular practice, not necessarily that benefit that we see in the ideal context will be translated to the patients. So it's not only about adoption, so making sure people are using the thyroid nodule risk stratification, but we also should focus in that they are doing it to the higher standards of care. Now, I think the paper that we just discussed really adds a lot of information to this kind of like conceptual framework. I wanted to point out a few. So one, although, you know, a high number of the individuals, so we're looking at the determinant from the individual who performed the intervention, notice an added value. There was also a third of the respondents that were not using the practice. Now, there's a room here for education of those of the third that are not interested in using the practice, but also there's room maybe for some new additional data to understand why they were not using the practice and what kind of information in terms of effectiveness they will need to make sure that they want to do risk stratification on a day-to-day basis. There were some findings in terms of the intervention itself. So that lack of agreement in terms of the content, of the numbers of categories and so on. And I think here is where this work is particularly important because it's trying to address those determinants at the level of the intervention, achieving consensus and having international endorsements that will give that eminence to using the thyroid nodule risk stratification. Then in terms of the individuals and the process, there were some discussions in the paper about, you know, needing further education. So people wanted to make sure that they were having self-efficacy to do the process. And from other papers, time for the risk stratification has been highlighted as a potential barrier. So here again, education so that people have the skills, but then also changes to the systems. And I already kind of like mentioned reimbursement, for example. And that leads to the last one, which is data that we learn in terms of the internal and external setting. So we saw that local consensus or the fact that your society endorses this, the eminence and the economics, and all of that will translate into an implementation strategy of having this as a requirement from the individual departments, and then even thinking broader or bigger how this could be translated into reimbursement. So in terms of next steps, I think this paper offers a lot of information about some of the determinants for thyroid nodule risk stratification. But I think there's space to do a kind of like a broader and a more systematic evaluation following this lens of implementation science, because that's the kind of like a problem that we have now. I think even if you're kind of like play devil's advocates, as I did, and highlight some of the shortcomings of thyroid nodule risk stratification, the net effect is going to be positive if this is done for most patients to high standards of care. So there's a need to really have a broader and systematic evaluation of the determinants for adoption and quality, and then develop implementation strategies that can address those determinants. There might be a need to adapt the intervention, as some of the work from the International Thyroid Nodule Ultrasound Working Group is showing. And then I think there's also space to even clarify what are the outcomes that we want to achieve with the thyroid nodule risk stratification. So just to kind of like sum up and put it all together. So we have thyroid nodule risk stratification as the evidence-based practice, potential outcomes that we can improve, such as the unnecessary biopsy, clinician communication, patient-centeredness, looking at all the people who are involved, and then the intervention, the process of the thyroid nodule risk stratification, and then kind of like their inner setting where they practice and the bigger context in which they are practicing. And then just coming in with potential interventions to increase adoption. So for the individuals, this is making sure that they perceive a gain of using thyroid nodule risk stratification, making sure that they are that they have self-efficacy to perform these assessments. In terms of the intervention, then use eminence, so make it endorsed, make it universal. In terms of the process, then help people with the time and help people with getting feedback on whether their reports are complete, on whether their rate of malignancy, depending on what they are calling the nodules, is comparable to the studies and so on. And then, you can always start from the individual and then move to the bigger kind of like setting where you work. That's most of the times it puts a lot of pressure or burden on the individual, but you can also do things to try to change the system. And that's where I think reimbursement and allowing more time, and as well as having it endorsed or recommended by clinical practices and society guidelines can have a big impact. So then at the end of the day, as you start getting more clarity and a better understanding of these determinants with the potential effects of interventions, then you will have increased adoption to high quality, and then really get the benefits of the evidence-based medicine intervention. So in conclusion, I would say that thyroid nodule risk stratification improves the quality of the diagnostic process for patients with thyroid nodules. There's the actual estimates of the adoption and quality in practice are variable. So this is another area where we need to focus to try to understand really how many patients with thyroid nodules are actually getting a risk stratification, and to what degree of reproducibility and quality. And then I believe that using an implementation science approach can help us understand the determinants that can lead to low adoption and low quality of risk stratification, and then develop and test strategies that can increase that adoption and sustainment of high quality thyroid nodule risk stratification in practice, so that patients actually benefit from all the research that has been done in this space. So thank you very much for the invitation, and again for the opportunity to provide some context to the excellent presentation of Dr. Hoang. If any of the things that I discussed you find interesting, please feel free to send me an email. So thank you, and happy to answer any questions.
Terrific. Thank you very much, Naykky, for that wonderful discussion. And Jenny, that was extremely useful and very helpful a review of that study. I must say, when I read the study, I was amazed at the number of respondents that you actually had. And so hats off to you that you were able to engage that many people in this discussion. I think one of the really important things, and I see JP Brito on the call, so I'm going to let JP weigh in on this as well. But where the vast majority of ultrasounds are being done for patients with thyroid nodules, I dare say, and I'm just guessing, that the majority of these are being done in a community setting rather than in academic medical centers. Jenny, do you have any statistics on that particular calculus?
I would say that, yeah, more than 2/3 are done in outside academic centers. We have a thyroid ultrasound registry with the ACR, and fortunate enough to engage 3 private practices and get some insight into the reports and in some ways the variability of reporting.
So it really begs the question: if the goal of this this initiative is to enhance the quality of ultrasonography reporting, interpretation, it really begs the question where the biggest error is. And so is it, do you have a sense, is it in that the clinician is misinterpreting what they're seeing on the ultrasound to be able to identify the appropriate features, or is that less of a concern or risk than in using those features to appropriately risk stratify?
I think that this is a really great question. It's multifactorial. There is always going to be inter-observer variability in the way we report the features. And that's problematic because it affects the categorization and then the recommendations. And as you know, in our own committees, we are creating CME programs. We have atlases and education like these webinars. But that is going to be a ongoing problem. But the main thing that risk stratification systems do is at least serve as a checklist to help radiologists and other interpreters of ultrasound to actually even think about the features and look at it and include it in their report, and then have a way of managing, recommending based on all those features. So it will be, as Naykky said, it's 17 years, it's going to be ongoing, and there will always be differences in our practice, but risk stratification systems are a great start.
So it seems to me that probably one solution, which we've all been sort of entertaining and reading about, is the use of AI to interpret imaging. And then I would imagine it would be, the next hurdle would be to apply that AI interpretation into a risk stratification system. Do you have any thoughts on that, and in terms of how that process would go? Because that seems to be the next frontier in achieving accuracy in ultrasonography.
Yeah, absolutely. I think that is the next frontier, and there are already products out there. At my time at Duke, we also did an AI project evaluating thyroid nodules. We didn't get to the point where we were able to categorize the features, but we did get to a point where we were able to predict malignancy with fairly high confidence, as much as a human reader.
I don't want to put you out of business here, but that seems to be the future trend here. I think one of the big questions that came from your survey, and I'll ask Naykky and as well as you, Jenny, to comment on this, is that with loyalty to region and to society being such a major determinant of adoption, how would you overcome that issue of loyalty if you then create a universal system that's once removed from regionality or society-based? Does your committee have thoughts on how you would get that? Obviously, one solution would be get those nations, get those societies to endorse it, and that might be a way. But have you given that thought?
Well, the members of that working group are actually representatives from all of the societies, and so we are on our way to working on the lexicon paper, and that will be published in the journals associated with those societies. So everyone's committed to that.
Great.
Yeah, I would think that that's the way that you kind of like take advantage of the fact that people have that loyalty, but you just now just say that everybody's in agreement and this is what we think we should do. So that it's probably going to be very, very strong. I would think maybe for Jenny, the harder part is going to be to make sure that everybody's in agreement within the committee with what you're going to be recommending at the end.
Great. I want to give JP Brito the last word here. JP, do you want to weigh in and give your thoughts or ask any additional questions?
Oh, then just congratulate. Can you hear me?
Yes.
Just to congratulate Dr. Singh Ospina and Dr. Hoang for these wonderful presentations. I can just say that this is fantastic effort that has been going on for years. So congratulations to both of you in the research that you're doing in this area. Something that perhaps I feel that is missing is the patient's voice in the whole spectrum of development and implementation. Why is that? Because I always find that the estimates of risk cancer that we provide, regardless of ATA or TI-RADS, I'm not sure to the extent to which they mean the same in the classification process than for patients. So we classify 20 to 70, 20 to 50. I'm not quite sure if patients actually, it makes a difference, 20 versus 10%. So it would be very interesting to see the extent to which those estimates of risk actually mean a lot to the patients. And the second thing is the reporting of these ultrasounds. Patients do read them before the clinicians read them, and they become very anxious about it. So it seems to be that in the reporting process, it needs to have a way that this is something that is also going to be read by patients, going to be appreciated by patients, appraised by patients. So it has to probably be more patient-centered in the way that we describe this, or develop systems that for patients not to read this before we actually talk to them. But in general, I think this is moving forward to more evidence-based practice in the thyroid nodule. So congratulations.
Great comments. My last question for Naykky and Jenny is, obviously we've got this point-based versus image-based or pattern-based approach. And I think of value to two different types of clinician who would want to use those. Would you envision that Jenny, the final composite lexicon will be a combination of those two, or is that impossible to achieve?
It's still work in progress. We've got the results of the survey which favor points-based, but that's the next stage. At this, it's going to be a discussion, and as Naykky said, that's achieving consensus is going to be the next challenge for us.
I'm thinking that from an implementation part, as Dr. Hoang mentioned, probably the point-based has some advantages in terms of education, serving as a checklist, kind of like the training, reproducibility, because the pattern-based might be kind of like more challenging, and also when you consider time. So I think in addition to the preference, as the optimal goal is adoption, and whatever of the panel members might believe, there might be some thought of thinking what would be easier to implement in practice, and comparing one with the other. So that would be another approach or another thing to consider when trying to answer that question. That maybe with the point-based or the pattern, in terms of diagnostic accuracy, there's a 2-3% difference, let's say, but the adoption of the point-based will be way easier. Then you'll probably favor that one, even if the diagnostic accuracy were to be different, which I don't think they are in any case. But just kind of like thinking of what would be easier for the user eventually might help on those discussions as well.
And particularly, Mark, as you say, if most of the users are not experts that are able to just make a decision on what it is after a couple of seconds, and they're mostly out in private practice in the community, then a points-based system is much easier.
Great. Well, we are over the 9 o'clock hour here. And I want to again thank both of you for outstanding presentations, really valuable educational material for our listeners this morning. And thank you to everybody for listening in, and invite you back next week for next week's presentation. That will be from Dr. Ian Ganley with a interesting discussion from Dr. Peter Sado. So everybody stay safe, and thank you once again for listening in. And thank you, Jenny and Naykky, for wonderful presentations.
Thank you.
Thank you for having us. Bye.
Great. Bye-bye now.